These Chinese doctors had given oral testosterone to men with angina, and they demonstrated a reduction in ST segment depression using Holter monitoring. That's all we had, and we became interested in it, and there are other workers, Webb and Rosano in Italy, have been interested in this area. So we did a randomized, placebo-controlled trial of testosterone replacement therapy using a skin patch in men with angina. We did it in all men, not just in hypogonadal men, but in all men. And we had 46 men, and it was a positive result. Those men on testosterone had an increased exercise tolerance and an increase in time to 1 millimeter ST segment depression on the treadmill, which is a hard endpoint of angina. And it was a 3-month study. But more importantly, we showed that those men who responded particularly were those who had a low level of testosterone to start with. These are the side effects we identified. One man had a heart attack on testosterone replacement therapy, and one man was depressed, significantly depressed, requiring intervention on placebo. This is a morbid population of men who have heart disease, so that wasn't too surprising. Because the effect of testosterone replacement seemed to be particularly only effective in men who have a low testosterone, we did another study where we just looked at men with a low level of testosterone, and they all had a highly significant benefit from testosterone replacement therapy. Over a year now, we've done a study over a year. The problem with many of the intervention studies, they're short-term, and we wanted to know whether once we replace testosterone, we lose the beneficial effect as the androgen receptor is downregulated once it's been replaced. And these data are data just published last year of testosterone replacement therapy for a year. And you can see it's a randomized controlled trial. You can see that those people on testosterone, as men on testosterone, had significant improvements in exercise tolerance and time to 1 millimeter ST segment depression on the treadmill, which actually seemed to be getting better every time we tested it, rather than worse. And these on placebo just varied around the baseline. We also looked at CIMT, carotid intermediate thickness. Our numbers were small, and we found that CIMT improved in those on treatment, but it wasn't significant. Body mass index fell, hemoglobin increased a bit, but not too much. And over a year, there were no adverse effects at all. What about heart failure? Well, vasodilators are very good in heart failure, but before we talk about that, let's talk about testosterone in heart failure. These Polish workers showed that if testosterone was low in men with heart failure, it was significantly adverse in terms of their prognosis. They followed patients up for only 18 months, and those who were testosterone deficient had a highly significant increase in mortality compared to those who weren't. They were also much more miserable. This is the depression index, and those with a low testosterone had a highly significant increase in depression. So depression and mortality is worse if you have a low testosterone. We don't know yet about cause and effect. We do know, though, that in men who have a low level of testosterone, if we give testosterone acutely, we do get a vasodilatory response. So the human model experiment, this is using Swan-Ganz catheterization, where we can monitor cardiac output, pulmonary vascular resistance, and systemic vascular resistance. Acute dosing study, we can demonstrate that testosterone is a vasodilator. We get an increase with testosterone in cardiac index and a reduction in systemic vascular resistance. So we know it does work as a vasodilator. So we studied testosterone in men with heart failure and showed an improvement in exercise tolerance in heart failure. This is a shuttle walk test, which is an incremental exercise test. It's on the flat, but they have to walk in between two cones, and the time that they have to do that shortens every time they do it, and so it's increasingly, if you like, stressful for them. These are the patients on placebo that, as you'd expect, over a year got consistently worse. The patients on testosterone got better. We used an androgen patch, I think it was called Andro patch. It's now been withdrawn, and the problem is that using patches you get a lot of skin sensitivity, and half our patients dropped out by 6 months because of skin sensitivity. And so we wondered whether this was a real loss of efficacy, or is it just because our numbers were falling. More importantly, again, we showed that men who had a low level of testosterone at the beginning had a much better improvement. These are the side effects we demonstrated over the year. On the placebo arm, we had significant increases. Well, not significant increases. We had more men with side effects like arrhythmia, diabetes, and there was only one death, and that was in the placebo arm. We had one stroke in the testosterone arm. We had lots of skin side effects, and we had a smattering of hospital admissions for other things. There was no significant difference between the two arms. Some Italian co-workers workers have done a very similar study looking at insulin, lots of other things as well as exercise capacity, but these are the exercise capacity. This is the change in peak VO2 max, which is a measure of exercise capacity on a treadmill, and look at the change with testosterone. So the bigger change in testosterone you get with replacement, the bigger change in exercise. And again, only 30% of their patients were frankly hypergonadal at the beginning, and they were given the Nebido preparation, which is a long-acting preparation of testosterone with no adverse effects. They've also done it in women, and they've used a low 300 microgram patch twice a week in women and showed significant improvements in insulin resistance, walking distance, muscle strength. And there were 2 patients in each limb who developed heart failure, so there was no real significant increase in side effects we could see. That was over a 3-month period as well. Testosterone has lots of other effects. It reduces cholesterol and LDL. There are lots of studies to show that. In our own studies of men who are already treated on statins, because most patients with heart disease are on statins, we still see a significant reduction in total cholesterol with testosterone replacement, and HDL goes up. We see a marked reduction in obesity. There's a loss in body surface, in waist circumference in our treatment studies, and in insulin resistance, which is a feature also of heart failure. We've demonstrated reduced inflammatory activation and cytokine activation and diabetic control. So testosterone doesn't seem to have any negative effects in terms of cardiovascular disease. Most of the things that we've measured and demonstrated are positive. But does it really matter if you have a low testosterone level? I've suggested that there are clear data that coronary disease is associated with a low testosterone level. Vascular disease generally is. What about mortality? Well, there have been 4 studies now showing a clear link between low testosterone level and mortality. The first was the Shores study, which was veterans, a VA study from the States, of men over 40 years who had 2 measures of testosterone. That's how they got into the study. They excluded patients who died within the first year because if you're systemically ill with anything, your testosterone is suppressed because of the effect on the hypothalamus. And they split their group into those with unequivocally low testosterone, less than 8.7 nanomoles per litre, a borderline testosterone level, a normal testosterone level, and they followed patient, and they looked at a follow-up over 8 years. And in their regression model, they adjusted for all those other clinical variables that are associated with mortality. And it's very clear that the 3 mortality curves separate, with the middle one there, but the low testosterone has an adverse mortality effect. Another study from Pomerania followed nearly 2,000 men for 7.2 years, and they defined a low testosterone level as less than 8.7 nanomoles per litre. They adjusted for all those usual factors associated with mortality, and they showed a highly significant effect as well of having a low testosterone. And there were also this very big study of nearly 12,000 men from England followed up over about 10 years. Patients here were excluded if they had cancer or heart disease at baseline. So these were, if you like, a clean population. They also exclude deaths in the first 2 years. And they looked at the effect of testosterone on mortality and were able to split it across all the quartiles. And so a low level of testosterone, intermediate and so on, were associated with a significant increase in mortality. Our own study of nearly 1,000 men who have coronary artery disease based on angiographic findings were followed up for 7 to 9 years. And we measured bioavailable testosterone. We actually measured bioavailable testosterone. You can calculate it, but we measured it.